So with that, we'll move to Dr. Ravinder Rao for our first live case. We can see that he's been patiently waiting. Sorry, we're coming to you late. But thank you again for joining us, and the stage is yours.
Hello.
Yes, we can hear you. Can you hear us?
Hi, Sushil. Yeah, we can hear you very well. Good morning from Jaipur. Thank you, TCT. Thank you, Dr. Srinivas Kumar and Sushil, for giving us this opportunity. So I think we'll go straight to our case. Uh, let's go to the next slide, please. This is our team. On my right is Dr. Kailash Chandra. He's an intervention cardiologist. Govind Sharma, intervention cardiologist. We have Prashant Vashne, who's a cardiac anesthetist. He also specializes in DE for mitral clip. We have Vikram Patil, who is a structural intervention fellow. Next slide. So I was supposed to do a TAVI on a young patient, bicuspid, and a self-expandable valve. So here's the patient, 74-year-old female, height 168, weight 84 kilogram, BMI of 29.8, body surface area of 1.98 meters square, GFR of 109, presence with dyspnea on exertion, NYHA class 3, hypertension, diagnosed to have severe aortic stenosis, was consulted for surgical AVR also, STS score of 3.19%. So the age is 74. So this is young for the, so at present, the average age of cohort, which we have patients for our cohort is around 72. So she's not young as per Indian standards, but yes, so the anatomy which you'll be seeing is kind of what we see in young patients. Next one. This is the echo finding. You can clearly see the mean gradient of 60 millimeters of mercury. Next slide. This is a CT scan analysis. The CT scan perimeter is 67.9. The average diameter is 21.1. The perimeter derived diameter is 21.6. The femoral vessel size is adequate. The coronary height is very good, 22 and 18.9. The sinus of valsalva diameter is also adequate. Next one. So this is what I want to draw your attention to. This is a type 0 bicuspid, and you can see calcium which is present on the leaflets. Next one. The ascending aorta, the sinus of valsalva diameter, the STJ diameter are well within limits. There is no dimension which is more than 4 centimeter in the entire ascending aorta. This is the intercommissural distance, which is 24.7. This is the circle methods for supraannular, comes around 69.3. Next one. And this is the implantus view. It's RAO4 caudal 17 and LAO 17 and caudal 2. So LAO 17 caudal 2, this is a type 0 bicuspid. So this is a derived angle on the 3-Mensio software where you bisect and make 3 cusps. So these are 3 cusps, and then you overlap those 2 cusps. So you get a cusp overlap view. Next one. Membranous septum height is 5.9. Next one. And you can see the femoral vessel, good size on both the sides. It's more than 6.5, 6 mm. Next one. So this is our plan. We want to do a transfemoral TAVI with conscious sedation. We have only one groin axis. We have a 14 French on the upper part, a lower one, 6 French long sheath, a 6 French vein, a temporary pacemaker. We have put a pacemaker. We want to pre-dilate with an 1820 balloon. We have chosen an Evolute Pro plus 26 millimeter valve. We'll do a post-dilatation with 20 mm if required. Temporary pacemaker will decide at the end of the procedure, and neurological assessment. One important thing which I want to draw your attention to, the body surface area of this patient. If you look at the body surface area was 1.98, and the dimensions for a balloon expandable was something around a 23 mm valve versus a 26 self-expandable valve. And you can see even the 26 self-expandable valve, this patient is in the yellow zone, just borderline between the yellow and the green zone for development of patient-person mismatch. Next one. So consideration and challenges. This is a young patient, type 0 bicuspid. These are the 2 things which we'll be considering. Future coronary access, I think this should be of no concern because coronaries are very high, 18 and 20 mm. For a future TAVR, avoiding PPI as well as PPM. So one of the goalposts here is the depth of implantation. We don't want to target a 0 depth in this patient. This is a type 0 bicuspid. We want to be, the membrane septum length, we know it's around 5.2 mm. So we want to be somewhere 3, 4 mm below the annular plane. So we'll not change that goalpost. Anything which is below 3 millimeter or 4 millimeter below the annular plane will accept that. Next one. This is just an overview of our center. We do all types of structural procedures, TAVR, TMVR, TEER, Basilica, trick valves, pulmonary valves. Next one. Next one. So here we are. So what we did is, this time we decided not to show a skin to skin TAVR procedure because we wanted to have a little more discussion. So she is there so we can have some more inputs. So if you can you focus on the groin? So we did an ultrasound guided access. Here's a 6 French long sheath. The sheath goes all the way up till thoracic aorta. So the pressure which you see is not a damped pressure. It is almost like a central aortic pressure. There is one ProGlide and a 14 French sheath above it, and the temporary pacemaker. So play the aortogram. So this is the aortogram in the RAO4 caudal 17, which is a derived cusp overlap view. So the reason I'm saying this is a type 0 bicuspid. So for the audience, this is like a derived cusp overlap view. Next one. Just show us the 3 cusp view also. Yeah. This is a LAO 17. Here you can see 2 cusps away from each other. Next one. Yeah. So if you can appreciate that calcified leaflet, the negative shadow which goes all the way just beneath the left main. So this aortogram, is kind of telling us that we might have some difficulty in crossing the valve. Next one. Next one. Next. So we took an AL2, but I'm going to go ahead. Next one. Next one. Next one. Yeah, next. Okay, scene minus. So we had a lot of difficulty in crossing the valve, and because of the eccentric opening, the valve, the wire was not growing. So we did this rapid pacing. You see, we did rapid pacing at almost 180, and we were making an attempt to cross the valve. Otherwise, we were ready to do a septal puncture, and that's when the valve crossed. So this type 0 bicuspids have a lot of challenges, and one of the challenges is because the opening is enteroposterior. So here we are, Dr. Sushil and Dr. Srinivas Kumar, and you can see the invasive hemodynamics, severe aortic stenosis, peak to peak gradient is almost 60.
So maybe just a few minutes for discussion before you go forward.
Yes.
You highlighted a lot of important issues. I mean, one, I understand that it's not a young patient by Indian standards, but maybe we can talk about it later in terms of lifetime management, but maybe comments from the panel here and a couple thoughts. In terms of, in a bicuspid, there's a lot of variability. This is a type 0 bicuspid, but eccentric calcium. The key question when you're doing any of these procedures is to get a seal, prevent leak, prevent pacemaker, get optimal hemodynamics. How does the anatomy factor into a valve choice? Do people look at this differently? In terms of sizing, there's a lot of different algorithms for sizing. Circle, Lyra, Casper, whatever you want to do. So maybe I'll ask some comments from the panel if people would look at it differently. Any thoughts?
Sushil?
Go to the LAO view, please.
Can you hear Ravinder?
Yes, I can hear. I can hear very well.
Anand here. Good morning.
Yeah,
Fantastic
morning.
case for discussion. I think Sushil has brought on some of the
LAO
key points to discuss with this case.
LAO
First is the sizing. I think now we have come to the conclusion that most of the cases you can size as you size for the tricuspid. So annular size will do well for 80% of the cases. In 20% of the cases, you probably need to see the ICD intercommissural distance. And if it is small or big, based on that, you can undersize or oversize your valve. And all the other methods are kind of liable for a lot of errors because this circular method, this Lyra method, all the other methods are very subjective on who is measuring it. So in this particular case, I think yours is very nicely fitting into the 26 valve. You can discuss between the R and Pro Plus. Obviously, we have got both here, but I think the Pro Plus will give you a nice seal without parallel leak.
So just to add to the discussion, we'll do this and then we can have more discussion. We have selected a 20 mm balloon because we also do a balloon sizing assessment for these bicuspid cases. So we'll do this balloon sizing. Okay, let's face it 180, please. Okay, go up. Inject. Okay, deflate and stop pacing.
That looks perfect. I think the 20 itself is giving you a nice seal. So your 26 should fit in well because 26 will have a 22 way. So it should be perfectly well. All the other parameters you mentioned in terms of your depth for future tab in tab, I think around 3 millimeters depth is ideal. Corners are good. So I don't think I will change too many things, Sushil, in terms of other things.
No, I
Um,
agree. I think this is a great, sorry, Dr. Mehta, go ahead.
Just one small comment. This might not be pertinent at this stage of time. That the right coronary has an anomalous origin, Ravindra,
Yes.
rising
Yes.
from the left side. So now that we are talking of durability and the future and one-time treatment with this kind of valve, this may be an additional problem while crossing the right coronary artery, just in case if this patient needs to have a right coronary artery treatment in down the line in 5, 7, 8, 9 years. Just an observation that the right is rising anomalously, and you have a supraannular valve, a large frame valve. And sure
Yeah,
enough, I think,
Yeah, I totally agree with you, sir. Now, the way we chose is now if this patient had a CAD, then there was a high possibility that this patient will develop coronary artery disease in future. Number two was most important thing was the coronary height. We saw RCA was almost 20 mm. The one additional thing which we do before we implant the valve is we will change our gloves because if you look at the explant TAVI registry, one of the reasons for an explant TAVI valve was infective endocarditis. So it's just we just wanted to share our practice just before we do a valve. We take valve in our hands. We will change our gloves one more time. So yes, sir. So to answer your question, yes, that's a concern. If this patient develops a RCA problem, hold it. RCA disease in future, the engagement will be a little challenging. But I think
That's
because
also one of the reasons, though, I think there's all this sort of thought about being very high with the implant in every
Yes.
case. And that's not always the right answer. In a scenario like this, where your membranous septum is long and your coronaries, being a little bit lower will give you easier access to the coronaries, will make valve and valve appropriate. So I think, we can't blanketly say we need a high implant, as you stated. And the sizing thing, I just want to emphasize again, that was an excellent point that fits well with annular sizing. The key question is there radial strength? Will it expand? And I think that's why doing the balloon first is an important component here.
Yeah, so that's why we use a 20 mm balloon because these type 0, show me about type 0 bicuspid, as you pointed out, Dr. Sushil, that the radial strength, sometimes when we have done self-expandables in these small anatomies, the valve does not really open up. And then you are in a big problem, whether to pull the valve out, deploy, and do a post-dilatation. Go, Leo.
Yes, so I actually recommend BAV in all bicuspids.
Yeah, hold the wire.
All large self-expanding valves like 34 revolute. At least that's our site. That's what we do, and heavy amount of calcium burden. So even if it's a tri-leaflet, more than 2,000 calcium score, and all valves that are less than 0.6 centimeters square. So even if it is balloon expandable, in all these situations, we still do it.
So, Sushil, with which condition would you use intercommercial distance and not the annular?
I think it's different. I mean, especially if
Caudal.
if it really tapers, if your annulus flares out and it's really small and you don't think you're going to expand in that direction, because if you oversize and cause trauma, it's really when it's more of a funnel shape that more about the intercommercial distance.
Yeah, that's good. So as we discussed, we're going to start at this level. We don't want to start at a zero depth. We're also looking at why our valve is a little bit on the inner curve. So we'll just push our wire a little so that we can come back slightly on the outer curve. And we're going to go back in here. Okay. Let's take one more picture.
In terms of wire choice, some people have advocated for Lunderquist. We use the Safari extra support which has advantage of some of the Lunderquist support, but as you're talking about going on the outer curve, and it's a more supportive wire necessary sometimes.
So what do you think about the starting position, Sushil, and all the experts on the panel?
Hey, Ravinder, it's Saurabh. How are you?
Hi, I'm absolutely fine. Pleasure talking to Saurabh. How are you?
Good. Just walked in late, so I didn't see the first slide. But I agree with Sushil that our default wire of choice now is Safari or a Confida rather than a Lunderquist. I think with these newer generation valves, that's just too much wire, and I've seen more LV perforations with that. We've also tended to use the wire a little less these days and just rely on the expansion characteristics of these newer generation. And then in terms of your question about depth, I like where you are. I agree that I wouldn't start too high here for a variety of reasons, but mostly to think about lifetime management.
Also
And I-
noticeably, I think the alignment is such that your head sign indicates that you are in all probability likely to achieve a good commissural alignment automatically with this kind of disposition of the valve with the head sign on that side and the tab on the other side.
Right. And, I
Great,
think
great.
part of the challenge in all these is that
Ready?
to maintain coaxiality. I think that, in certain anatomies, it's difficult. You can see it, at least under the
Let's
left
space
side,
at 160.
here it might be low. I think Saurabh mentioned the Evolute FX, which is
ahead.
what,
Slowly.
there are some advantages
Yeah.
to that.
Keep going.
It has the three dots that
Keep
are
going.
just
Go
above
faster, faster.
at 3 millimeters to allow us to really look at
Keep
depth.
going, keep going.
And it
One
really
more time.
helps and it
Okay.
tests to
Stop
see much
pacing.
more.
Slow to save. Okay. Let's take a picture there.
I think
Inject.
also I want the operators to watch.
Yeah.
Now, Ravinder is controlling the valve as well as controlling the wire, whether the second operator is deploying it, because that way it gives you a much better control in terms of adjusting the wire, making it coaxial. That looks beautiful.
So, I mean, as we discussed, we're not going to change our goalpost here too many. It looks a little deeper on the left side, but you see how the valve is it's totally on the inner curve. And once we maintain a forward pressure, probably it's going to align a little better. But if you look at the EKG, we don't see any changes in the EKG. It's still a narrow QRS. I'm okay with this position. What does the panel thinks?
I agree. I think a little forward pressure, and I think it
Yeah.
will come up on the left side. I think if
Yeah.
you try to put it 0 on these bicuspids also, you can pop up a little bit.
Agreed.
And
So I'll pull back my wire. I'll maintain a forward pressure, and then we're gonna go ahead and release slowly. So let's see. Wait a minute. Yeah, one turn at a time. Good. Slow. Wait a minute here. Let's take one more picture. Inject. Okay. So
do
looks
you
good.
pace for final release or no?
I do if my pressure is too high or if there are too many ectopics. We're gonna go ahead and pace in this particular patient at 140. Pace at 140, please. But most important is pull back the wire. Go ahead.
Do you go to LAO for your final
Yeah.
1/3 deployment,
Right.
Ravinder, or do you do it in this session?
So this is a type 0 bicuspid. That's what I mean. If it's a tricuspid valve, leave this thing. Yeah, let me go give a forward pressure. Go ahead, release.
I
Yeah,
think
go
it was an LAO caudal.
Yeah.
So
Yeah, go ahead, release now. Go ahead, release, release, release,
I like to usually pull my pigtail
release,
back just because
release,
self-expanding valves, we're trying to be higher.
yeah, release,
It doesn't add any
Release
more
faster. Yeah.
need for
Faster.
keeping
One
the
more time.
pigtail
Yeah.
there.
Okay, one more time. Yeah, it's still there. So you can see the tab is leave. So we're gonna push forward.
I think Ravinder's pointing the
Fluoro
tab is
save.
fully passed. It's important to ensure, as he did there, that the tab is fully released.
Stop pacing, please.
Yeah, there we go. Yeah.
So pull back the wire, we'll pull back the nose cone. You know what? Sometimes this nose cone also catches onto that tab.
Yes.
Okay, so come to AP view. So I was talking about the tab which is there on the outflow. It has happened the nose cone caught into one of the tabs, so you push the wire back and realign. So the valve is released, and if you can see the hemodynamics, let's recapture the valve now, please. Nose cone. Yeah, go ahead. Yeah, show us about. Yeah, go walk it out. So EKG, no change in QRS, still narrow QRS. You can see the diastolic pressure, which is 70 millimeters of mercury. And I'll take a cine just for the depth. I think this is what we wanted. We are almost around 3 to 4. Let's mag up. Yeah, go ahead. Wire, please. Careful. That's okay. That's fine. Let's put a sheet and let's put, okay. So the pigtail, jailing of the pigtail, either ways, I mean, we almost always jail unless the sinotubular junction is very small and we fear that the valve can trap the pigtail at the level of STJ. Let's just focus on the hemodynamics, please. Hemodynamics. Okay. And if time permits, we would also like to engage the coronary artery because, these are the important discussions for a young patient. Now, suppose if there's a coronary access problem, we will engage with the catheter. We will write in our discharge summary that such and such a catheter was used to engage the coronary arteries. Anybody thinks there is residual AR in this patient?
I mean, the diastolic pressure looks good.
Yeah,
And if you could go RAO, can we just see the expansion of the valve as you
come,
rotate?
yeah, come RAO, please, mag up, just one magnification. Wait a minute now. Okay, RAO, keep coming RAO, RAO out, RAO, more R. Okay, remove the parallax.
So
Okay.
what's good, what you see here, sometimes in bicuspids or a lot of calcium, you'll see
Got
that it's not, when you go RAO, that the valve is not expanded. And that's when even sometimes I'll show a case later where you consider ballooning it just for expansion of the valve and valve function and hemodynamics, but here it looks like there's good expansion.
I agree. It has happened with us also. In the LAO view, it looked very good. In the RAO view, it was like a crescent. It was just not opening. So this is our hemodynamic tracings. So no gradients and no hemodynamically significant aortic regurgitation. So we're not planning to do any pre-post dilation in this patient, but what we'll do, we'll go ahead and do an aortogram and let's see. Okay, show me the pigtail, please. And get me a JL diagnostic.
Yes.
JL4. Remove the parallax. Caudal out. Caudal out. Okay. Center, please. Center.
That's the beauty of this valve, Ravinder. No
Okay, let's
paravalvular
take-
leaks, no gradient, and
Inject.
proplex it seals.
Let's
so
inject 15 ml, please. We don't have to inject less, but there's actually no paravalvular leak. So let's see.
well. No, this
15
diastolic is good 70.
Yeah. So we'll inject. We'll take one more picture. Inject. And you see this depth which I was talking about. This is exactly what we have achieved. The reason I want to highlight this, sometimes when you're doing this TAVI, especially with a self-expandable valve, when we were before releasing, on the left side, it was looking really deep. You would recapture, but again, you'll have the same position. You're going to recapture again, it's going to go to the same position. So you also understand how the valve is going to sit at the final position when you release it. And that's what has happened. You maintain a forward pressure, pull back the wire, and the valve reorients itself to the right depth. So here we are. We're going to go ahead and
Well, I
remove the
think that-
pigtail.
I think that
Sorry.
orientation thing and getting coaxial is an important component. The next generation, the Evolute FX, in addition to, they have markers at the commissural post, but those markers are 3 millimeters from the bottom. They allow you to better gauge depth, but also the mechanism, the delivery catheter tends to centralize more and get a little bit more coaxial. So I think there are iterations that are going to continue to improve to help with this, but I mean, this is a challenging anatomy and it's a great result. We have about 5 minutes maybe before we go to the
Okay.
next case. If
Yeah.
you want to show us the coronary, that'd be great.
Yeah, I'll show the coronary. And Sushil, we also we want to highlight the single axis, single groin. Now we use for a lot of these TAVR patients, provided the groin axis is at least 6.5 or 7. Go to LAO, please.
So are you using wire, or you or anyone on the panel, are they routinely using wire pacing?
I do, but not for balloon expandables. So this particular patient, and then we decided to put a temporary pacemaker because the alligator clip for some reason was not functioning. But I don't use it for balloon expandables. Yes, for self-expandables, I would use, we are below the leaflet.
Yeah, we're using a little bit, not
Go to LAO cranial, please.
100%. How about you, Sushil? Are you using?
Cranial?
Rarely, and now they have the Savvy wire, which is the hemodynamics and pacing. So we tried a couple cases last week and it went well because we just got it. But then it obviously adds another cost issue into the procedure. So I'm not sure where we'll be routinely.
So you see how high the coronary is in this particular patient. And okay, let's do a shot there. So this coronary artery is arising above the sinotubular junction in this particular patient. So, okay, let's see.
Yeah.
Ravinder, this is a diagnostic catheter. It's probably, I think it's 3.5. Am I right?
Yeah, we'll take a 3. I mean, guiding 3.0.
3 doesn't come in the
Yeah, guiding
diagnostic, so
catheter.
the guide 3
Yeah.
would be an appropriate. Yeah.
I agree.
Yeah.
So get me a 3O EBO or an XP.
XP3.
I mean, this highlights one of the challenges though. You do a TAVR. This patient has a STEMI, goes to a center that doesn't do TAVR. How do you navigate that? Are there opportunities to people, is there educational things?
Come
in
to AP view.
interventional cardiology meetings to talk about it? Because there are a lot of cardiologists that don't do.
AP Anna?
We're gonna see these patients for MI.
I think it's gonna be an issue. I think it's a good idea to do this and show that the coronaries could be cannulated with this. Because the TAVR guys are the people who are more experienced with these cannulations. So I think it'd be a good idea to routinely try to do this. If you think.
Yes, I agree, sir.
The right is also anomalous. I think you'll need some, different. catheter.
Ajit, I would say right is anomalous is a boon. Because I'll tell you, the catheterizing the right coronary artery in a supraannular valve like this is much more difficult than the left. And so since it's arising from the left, maybe it's a boon in disguise.
So I mean, even if we show that we can cannulate here, in the time of an acute MI, patient may not come to our cardiologist, right? It could go anywhere, and I still think that especially in younger people, I mean, at least in our center, 75 and older or younger, and then if they have anomalous coronary arteries, we either prefer balloon expandable valve over expanding valve. Then that's the new generation of self-expanding valve, or even evolute, and now actually in India you already have Hydra, which has much larger cells, easy to access the coronaries, and obviously with the accurate neo as well. But I think even if you had used accurate neo, the origin of the coronaries are so high, it still will be very difficult in this particular patient.
The other thing is sometimes the only reason you choose type of valves is these patients have baseline normal coronaries. So now sometimes, if you're not able to do a selective engagement, even a non-selective, a wire and a guideliner approach helps in such patients. But at least we should be able to come close to the ostium.
And absolutely, I think for people who are not routine TAVR operators, if they end up with one of these cases, you start with an iotogram first. Take an iotogram. You can identify easily the origin of the coronary and the cell you want to cross in. Maybe do it in two orthogonal views, LIO or AO. Then you will be able to identify the cell where you want to cross it. If you find there is a frame or kind of wire across the coronary, then as you said, you just float a wire and then a guide extension and then a guide, so that it will be easy for you. So start with an iotogram.
Okay, let's take a picture here.
Yeah, no, I think this is interesting and highlights some of the challenges. In an elective scenario, if someone has non-STEMI chest pain, someone has a TAVR, it's actually very reasonable to get a coronary CTA to start. Elective, because it may make the diagnosis, but two, it will show you the orientation and help you with engaging. What we can do is we have another case.
Let's see.
No, if you need some time to sort of look at it, we can also come back to you in about 15-20 minutes.
Okay, so yeah, done. So by that time we'll engage the Sushil, but thank you very much. So this was a self-expandable, low risk bicuspid, type 0 bicuspid. We achieved our goals of no paravalvular leak, no pacemaker, no patient process mismatch. And the last one is to engage the coronaries. So we'll be back.
Come back to you then. Thank you very much so far. Excellent demonstration. Okay, so maybe if we can, Ravinder,
yes, yes, Sushil will show you. Go to the next one. So we took an AL1, next one, come, straight to the, hold on. So AL1 engaged nicely, coaxial to the left main, if you can see that. Sushil, can you see the AL2?
Yes. That's unexpected. I would think an AL1 would be too big with the Evolute. That's interesting.
So the reason I chose AL1 is because, when I was trying to cross the valve, every time the wire was going to AL1. So I thought, let me try the AL1 diagnostic. And it's sat coaxial. The other thing is, for the audience, you go to the LAO cranial and make sure the interaction with the left main and the valve frame.
I think every aspect of the procedure you take in, because when you're trying to cross the valve, as you said, aortic valve with an AL, it was repeatedly going into the left coronary.
Yes.
So your thoughts going back there and taking an AL1 is perfect.
So, and then we just use right groin. We have removed all the sheath. We used one throw glide. Show the last picture. Autogram. Next one. Next one. Yeah, that's. So there's a sheath below the access port. So we do an angiogram. We make sure there's no bleeding, no complication. We're going to go ahead and remove. So temporary pacemaker is out. Both the sheaths are out. Patient has narrow QRS. The mean gradient on echo is 8 millimeters of mercury. So we also repeat an echo before patient leaves the cath lab, because sometimes we are in for surprise and the patient is getting discharged and that mean gradient is in double digits. So this is from our side. Thank you very much.
That's a great example, a great case. I know the single access, what percentage of your cases are single access?
I would say not more than 10%, because I'm
Mhm.
looking for a vessel size of at least more than 7 mm for me to put 2 sheets. But the second sheet, I would always use a long sheet all the way till abdominal aorta.
I see.
Because sometimes the pigtail is trapped by the valve system, and then we are not able to maneuver the pigtail if the sheet is a short sheet.
That's a great point. Samir Kapadia always talks to me. I think they do the majority of their cases this way. I still haven't switched though, but I think it's an interesting idea that you just have one groin and you can sort of, not have to deal with the contralateral groin complications. So, go ahead.
Yeah, Ravinder, I didn't see you hook the right. That was anomalous too.
No, that's why I didn't hook it.
Thanks, Ravinder. That's fantastic.
Thank you, sir.
Yeah.
Thank you, everybody. Thank you, Srinivas Kumar and TCT.
Thank you so much.